Nau mai haramai ki tēnei zui, mō te korero ki te mate puku puku uma me te werohanga COVID. So welcome everybody, and thanks so much for joining us in this Zoom hui or Zui to discuss COVID vaccination and advanced breast cancer. So as Terry mentioned, Sweet Louise and BCAC, Breast Cancer Aotearoa Coalition and Metavivors NZ got together to organise this evening. And really we were just thinking it's challenging enough to be going through advanced breast cancer, let alone having to navigate your way through a pandemic. So we've invited a panel of experts here tonight to give us their thoughts and to answer any questions at all that you might have about COVID vaccination while you're on treatment. We're hugely grateful to have 3 doctors in the house tonight. So we have Morgan Edwards, who is an Auckland obstetric anaesthetist, and Morgan has done some great work engaging online to help people understand the vaccine. Right, and we have Richard Isaacs, 2 of our favourite oncologists, of course, Richard Isaacs from Palmerston North and Sarah Barton from Wellington here. So they know all about advanced breast cancer, all of the treatments that you're having, and they're your experts, your go-to people tonight. So first of all, I'll ask the panelists to introduce themselves and to give us their thoughts on vaccination. And then Morgan will actually give us a brief presentation. So Morgan will give us a brief presentation on COVID and the Pfizer vaccine, and then we'll move to your questions. And we're thinking that we'll do it by chat just because of the number of people who are in the meeting tonight. But if it seems really manageable, then we'll just do it verbally. And in that case, we'll get you to put your hand up using reactions at the bottom of your screen. So Richard, we'd love to have you introduce yourself to us.
Thank you, Libby. Thanks for having me along. As you mentioned, I'm a medical oncologist in Palmerston North. As a consultant, I've been managing women with early and advanced breast cancer there since 1996, so a very long time. As a background, I trained in Auckland, Palmy and Oxford, where I worked on molecular aspects of breast cancer for about 4 years. On coming home, I've been heavily involved with the Breast Cancer Special Interest Group. I've been an investigator on many clinical trials. I've been the New Zealand board member on the Breast Cancer Trials Group for the last 9 years. And I'm also on the Specialist Advisory Committee to PharmAC, where we assess new treatments for breast and other cancers. With that background, I think I've always advocated for best treatment for women with early and advanced breast cancer. And I strongly believe that vaccination is a critical aspect of that management. And look forward to our discussion tonight.
Thanks, Richard. Sarah.
Hi everyone, kia ora. I'm a medical oncologist at Wellington, Capital Coast DHB. I have a special interest in breast cancer. I've been working there since 2013. Prior to that, I did a fellowship at the Royal Marsden in London. And I'm currently the secretary for the New Zealand Breast Cancer Special Interest Group. And I am keen to take part tonight because I'm passionate about the people having the COVID vaccine. I think it's a really important thing that we can do to protect ourselves against COVID, and that's particularly important in women with advanced breast cancer because of the higher risk of having severe COVID and dying from COVID. And I think that it's the most important thing we can do to protect ourselves against COVID. So that's why I'm interested in taking part tonight, and hope we can have a good hui. Thanks,
That's
everyone.
Great, thanks, Sarah. Lovely. Morgan.
Kia ora, ko Morgan Edwards tōku ingoa, and I want to apologise that my internet connection sometimes drops out, despite being in the middle of central Auckland and having fibre. So that's just a bit of a warning that could happen. So I might try and share my screen, see if that works. So I can just pop up a little, here we go. Are people able to see that?
Yes.
Yeah, great. So we'll just have a bit of a talk through some things about COVID and about the vaccine. So, and this is a little bit about me. So I am a Waitemata DHB based anaesthetist, which might seem like a strange person to be speaking about COVID and vaccination. And essentially I went on a bit of a journey online, initially speaking about things much more within my scope and my specialty, and then have found myself really pivoting into this space, and now have 47,000 followers and speak basically only about COVID. And so it's meant that I've really got to immerse myself in the space and speak to lots of other experts, and developed a little bit of knowledge about that. I also have a science degree in pharmacology, which is the study of drug design, which I did before medical school, which I never envisaged being useful. But it turns out that the study of drug design and vaccines is now incredibly useful. So I'm finally, many years later, using it. So just going to have a brief talk about COVID, vaccines, the Pfizer vaccine and the third dose, just at a really basic level, so we're sort of all on the same page. And I apologize in advance if I'm telling you things that you already know. There's such different levels of literacy and understanding for this virus and the vaccines, and there's such a barrage of information all the time. I thought we'd just start with a nice level playing field. Just a really brief overline of where we've kind of come, because in some ways it feels like it's been such a long period of time, but actually it's only been since December 2019 when we went from that first case, and then just over a year later began offering vaccination in Aotearoa. I always reflect on the journey that we went on. On the picture on the left is a picture of an anaesthetist in Wuhan intubating a patient with COVID. And I remember seeing it in December or perhaps January and just thinking how absolutely ludicrous they looked, dressed up in all of these clothes. And kind of having a bit of a laugh with some colleagues. And the joke is on us, because in the middle and on the right, that's me, dressed up intubating a patient, and on the right running some simulation sessions, teaching my colleagues how to do the same. And that was within 3 months. And I just find that sort of succession of images so telling of the things when we first heard about this pandemic. We never thought we'd still be here however many months later. So SARS-CoV-2, it's not the first coronavirus. It occurs in humans. It's known to cause respiratory and GI symptoms. We've also had SARS, which was the severe acute respiratory syndrome, which originated in Asia in bats, and then MERS, which was a Middle Eastern respiratory syndrome, which went from bats to camels. So we had a little bit of experience before. I thought I'd briefly touch on spike proteins. It's such a phrase that is just, we've never used it so much in the last, 1 year, but it's actually not a completely foreign concept. So these coronaviruses, they have spike proteins, which are the little spikes that they occur on the outside of all coronaviruses, but they're quite unique to that group of viruses. And they're what allows them to attach to human cells and replicate. And I think that we all probably have heard about them in the context of the vaccines and how they utilize this really unique feature. But sometimes we can forget that it's actually coronavirus itself that has spike proteins also, and that's why the vaccines utilize them. In terms of how the SARS-CoV-2 infects us, so viruses, unlike bacteria and fungi, which can survive outside the host cell, coronavirus needs to be incorporated into a host cell, such as a human body cell, in order to replicate and transmit. So using the spike protein on the surface, it attaches to a human host cell, incorporates itself into the cell, and then replicates. Viruses continue to replicate, and this is how they're transmitted.
Okay, we're having some sound problems, I think. So could everyone except Morgan please mute themselves? Should be good now,
Are we okay to keep going?
Yes, we are.
Okay. Good. So yes, so most of the time when there's a mutation, then it either has no effect or it can be terminal. So in meaning that the virus itself would be unable to continue to exist. But the mutations can be advantageous viruses, and this new strain will occur, and they can attach to the host cell more rapidly, like more severe disease, or they can make vaccines less effective. And essentially what's happened with Delta is that it can it doesn't cause necessarily a more severe disease, but it does infect much more rapidly. And we talk about R0 values, which is for every one person in a completely unvaccinated population with no public health measures. So just kind of, the first time we see it, if one person is infected, how many people will they go on to infect? I think we hear this phrase so often in the daily stand-ups talking about where we're at with our R value. So sort of the original ones were sitting perhaps around 3. So by 3 to 4 generations, you're looking at 40 people, whereas the R0 of Delta is 6. So by the time we're getting to our 4th generation, that's 259 people that are infected from that one person. So the difference in the R values actually makes a huge difference. And that's really what is just so damaging about Delta. So then we think, how do we reduce that? And this is all the stuff that we know about, the Swiss cheese protection against the pandemic, where we've got lots of things and nothing's perfect in itself, but when we put it all together, hopefully the holes don't line up and we're able to reduce the impact. And so it's the things we know about. It's physical distancing, it's mask wearing, it's lockdowns, it's isolation of cases, it's contact tracing, and it's vaccinations. So vaccinations, we all know about, they've been one of the most phenomenal public health advancements that we've had in the last century. They work by a couple of different ways, but essentially we present the body with a weak, dead, and inactivated or synthetic form of the pathogen to then teach our body how to respond. The body then develops antibodies that then are able to, if exposed to the actual pathogen itself, your antibodies know how to fight it already. So the Pfizer vaccine contains the genetic code for the spike protein. It doesn't contain live, dead, or inactivated part of the virus, just a small code. After you're vaccinated, your body makes copies of the spike protein using the code, and then your immune system makes antibodies to the spike protein, learns, memorizes how to identify the spike protein, and then fight them in the future. I read a tweet that said, think of it as an email that's sent to your immune system that shows exactly what the virus looks like with instructions to kill it, and then just like a Snapchat message, it disappears forever. So the mRNA itself actually goes away really quickly within a couple of days. And then, we have a second dose, or, in some circumstances, a third primary dose in order to teach our immune system properly. One of the questions I find people in general ask the most is, how on earth was this developed so quickly? When in actual fact, the mRNA technology, whilst this is the first time we've used it in a large vaccine rollout like this, mRNA was discovered in the early 1960s. Research into how it could be delivered into cells was done in the 70s. The first mRNA flu vaccines were tested during the early 1990s, which was shockingly to me 30 years ago, which really doesn't feel like that at all. mRNA vaccines for rabies were first tested in humans in 2013. And so because of, they weren't brought to market and used because they weren't effective, but it wasn't because they were harmful. So we've actually been using these vaccines for a very long time, or this technology for a very long time, but just not effectively. And the reason it was able to come so quickly was because of this immense collaboration, scientific collaboration, because of this horrendous pandemic that we're in. This is just a sort of nice illustrative of it all happening in a line when we look at the idea, the basic research, and then we get into our preclinical and our then clinical trials. And the different phases of trials have increasing numbers of voluntary participants, and usually they happen one after the other. What's happened with this vaccine is that they've all kind of happened in parallel, and with, at the time, Pfizer and other companies taking a punt and starting to be prepared to start mass producing once approval was given, which could have all fallen over very poorly for them if they hadn't managed to actually produce, if the vaccine hadn't turned out to be safe. But fortunately for them and for the rest of the world, that punt did pay off, and that's why we were able to get it. Now, those original clinical trials, they were small, there were only 2,000 people or so. So most of our knowledge doesn't actually come from these Pfizer clinical trials. And that's probably one of the biggest pieces of misinformation that people don't seem to understand, and understandably so, that these Pfizer trials are important for the actual process, but they're only studied in healthy people who are volunteers, just really controlled situations, and they're small, whereas actually we have real world data. We've given more than 7 billion doses of vaccines, and a cautious estimate of at least 1 billion doses of Pfizer to every single type of person in the world, different ages, different comorbidities, different body shapes, different genetic backgrounds, and that data is much more valuable to us when we think about safety than those original Pfizer trials and our patients. Currently there's more than 10,000 clinical trials and observational studies ongoing looking at COVID-19 and vaccination alone. I mean, no one's really studying anything else. The entire world has its attentions turned to this pandemic. Another thing people often ask is what is actually in the vaccine. The only active ingredient is the mRNA. It contains the genetic material that provides the instructions on how to make the spike protein. There's sometimes rumors that mRNA will alter our DNA, which is completely untrue. MR vaccines don't enter the cell, which is where our DNA is held. DNA is actually upstream of the process that happens in our body. So we go from DNA to mRNA to protein. And for this particular type of virus, we can't actually go backwards. Like, it's actually physically impossible. And then once the viral protein is made, the mRNA is broken down and disappears. So we've also got lipids. Because mRNA is really fragile, it needs to be enclosed in a fatty sphere that helps protect it as it's injected into the body. So these are sort of what the lipids are doing. And then we've got salts, including normal table salt, which work to keep the right pH level in the vaccine. And then we've got basic table sugar, which can also be found. How do we monitor safety? Really, that's just by the ongoing Pfizer monitoring, which is a phase 4 trial, which is again routine, that we continue to monitor drugs once they're made and once they've been released to market. It's very, very routine for all medications to be continued to monitor. And then individual countries also monitor reports of side effects. So in New Zealand, that's CALM. You may have heard of VAERS, which is the American one. And then there's other examples around the world, such as Yellow Card in the UK. When we talk about adverse reactions, what we talk about, what is a side effect? It's an accompanying undesirable effect to a drug's intended effect. When we think about things, there's common things that pain, redness or swelling, which is just a sign of your immune system responding. Then you've got uncommon side effects. And then the ones that we worry about will get a lot of attention, such as myocarditis and anaphylaxis. Anaphylaxis being a potentially life-threatening, but also incredibly treatable allergic type reaction. And the incidence of anaphylaxis is actually incredibly low to this vaccine, much lower than something like peanuts, for example. Just to quickly touch on myocarditis. So this inflammation of the heart muscle can be caused by a variety of things, such as COVID the virus. It's usually relatively mild. You can get a bit of chest pain, feel an abnormal heartbeat, a bit short of breath. And most people that get myocarditis, and it's common and it happens, completely separate to this vaccine, every day in the hospitals around Aotearoa, there would be people presenting with myocarditis. And most of the time people can be managed at home or perhaps have a short hospital stay, and it's incredibly rare for there to be anything more serious or long-term come from it. I think it's really important to acknowledge that there's COVID infection rather than the vaccination. Things like what are not side effects that we don't see with the vaccine, but people do worry about. So getting COVID-19, we can't get it, it's not live. So whilst anaphylactic shock can be fatal if untreated, this is very rare. And we've obviously had the one death for myocarditis in Aotearoa. The United States has not had one death. It's incredibly uncommon. I'm obviously very sad for that person and their whānau. Again, autism, that's something that's just doesn't seem to go away as being linked to vaccines, but there's no data to demonstrate any link between the two. Infertility and DNA alteration, again, no link there. And this, I really like this image showing it's all about context. So in the red bars, we've got our risk difference per 100,000 people who had COVID-19 versus the people who were vaccinated. And aside from lymphadenopathy, which is your temporary response to the vaccine indicating an immune system responding, you'll see that things that are potentially side effects are much more common to occur with COVID, the virus itself. When we look at the effectiveness, sometimes people worry about that. How effective is it actually working? And so this is just some of the Pfizer data, what they showed. And they showed, that they had that disease transmission was initially 96%, dropping down to 84% by 4 months. And then severe disease protection was 97% at 7 days. Then we got out into the real world and real people and saw that there was that drop in protection by the time we got to, a longer period of time. There was a bit of a difference between some UK and some Israel data, where the UK seems to show a longer period of protection against Delta versus Israel. It sort of felt like that was perhaps because in Israel they vaccinated the older and more vulnerable people first, and they also test a lot more. So it may be because the population is more likely to get sick, or maybe because they're picking up on people who are sick more often. How does this actually translate to your risk of passing COVID on if you're vaccinated? What I think is really important, and I just keep on coming back to time and time again, is that if you're vaccinated, whilst you still can possibly get it, even right after you've had the vaccine, there is still a very small risk of you getting it. But as time goes on, that may increase. You are much, much, much less likely to get it. Lots of studies have shown that you're likely to have a lower viral load over the course of your infection if you do get it. You may reach the same peak viral load. You may have heard people mentioning that, but that particular right at the peak being as high does not mean that you have the same amount of viral load over the course of your illness. Viral load talking about how much virus you've got, and viral load doesn't actually also mean how effective you're going to be. And so we know from several studies that people who are vaccinated, even when they've got it, are much less likely to pass it on. And you're also likely to be sicker for a much shorter period of time. So all in all, much less likely to pass it on. What about immune compromised people? So like with many other populations of interest, and it's just one of these things that is the bias that happens within science, the people who need the interventions the most often excluded. The other group I think of is being pregnant people. We've got immune compromised people who we know we get incredibly unwell and much more vulnerable to COVID. Then we've got pregnant people, we've got, young, predominantly female frontline healthcare service who were also excluded. And so here we go. There have now been subsequent studies looking into some subgroups of immune compromised people showing the vaccine was safe. There was no episodes of rejection or graft versus host disease, fewer side effects, and then as we know, third dose is now advised. And I'm sure you're all across this, but just to delineate the difference between a third dose and a booster. So a third dose is, for somebody who, people who may not have generated an effective protective response to the standard 2 doses, but due to being immunocompromised, recommended to have a third dose just to get the same effect that somebody who isn't immune compromised might just get from 2 doses. So it's really just part of the primary dosing schedule. And that's endorsed by the WHO, this approach, whereas a booster is something that is aimed at addressing waning immunity over time. And then just to come back to our other methods, looking at the fact that, remembering vaccination is one very important part of the Swiss cheese, but then so is Bangladesh showing that surgical masks are also incredibly important. And I think that is a whistle-stop tour of COVID and the vaccine and where we're at with that.
That's fantastic, Morgan. Thanks so much. That was an information-rich very convincing presentation that there are so many benefits from having the vaccine and very few disadvantages, and including in immune compromised people. So we'll move on then to the questions that people submitted prior, and then the odd one is coming through in chat. So thanks for that. And if you have something to ask in particular about something that Morgan said, do put that in chat as well, and we will feed that back to Morgan. Okay, so the questions we've had that people submitted, I've been recalled for my 3rd jab, and then I'll be due for a booster in 6 months. My first 2 jabs were fine, but I have an immune compromised friend who had her 3rd vaccine and has been quite unwell. I'm also having a brain MRI and my 3-monthly Zoladex jab all in the same week. So what should I do about the timing of all of that and vaccination? Might be one for the oncologist, perhaps.
Well, neither Zoladex or the brain MRI is going to have any effect on immunity. I'd be getting on and having the vaccine. The fact that this lady had no reaction to the first 2 would suggest that she'd probably tolerate the 3rd quite well. Much more important to get protected.
Great, thanks. Some have said that the 3rd shot has caused some side effects for them. Do we need it? I think that perhaps Morgan might answer that one.
Yeah, so I think that we have seen from the looking at the other studies that the immune response from 2 doses in immune compromised people just isn't quite there to provide the protection that we would want in this population that is just much more vulnerable to effects of COVID-19. So it's broadly endorsed by bodies whose sole intention is really to protect immune compromised people. Like I said, from the studies looking into side effects, and they actually found that compared to non-immune compromised people, the side effects were actually lower. But that's not to say that you won't have side effects, and they can be, you can feel quite awful for a day or 2. But I think it's important to bear in mind that context that in Aotearoa we do have COVID in the community. We are most likely going to be exposed to it at some stage, and being protected is absolutely the most important thing.
Great, thanks, Morgan. And if I have the 3rd shot, will I need my 6-month booster? I think Sarah might be going to answer that one.
Oh, well, I think probably Morgan could answer that more clearly than me, but I think as she pointed out in the slides, it's not an alternative thing. It's important to have the 3rd COVID vaccine if you're immune compromised, and you'll still need the booster, but probably not until 6 months later.
Right, thank you. Okay, and there has been a lot of confusion. We've seen this from a number of different people who've said their oncology nurse says that being on Ibrance doesn't qualify them for a 3rd jab as it's not chemotherapy. I think that the definition that the Ministry of Health has put up on their website isn't very helpful, and certainly a number of people are encountering that. So what's our oncologist's response to that?
Well, I'm certainly treating palbociclib as an immune suppressing drug, and I'm recommending all patients on palbociclib get the 3rd COVID dose. And I think I agree, it's a little, as the guidelines are worded, it is open to interpretation, but I think most oncologists around the country, although they also acknowledge palbociclib is not chemotherapy, it is targeted therapy, but it is immune compromising and fall into that category, I believe. Richard, do you?
100%. 100%. I mean, there's a slightly increased risk of less serious infections with palbo, and while you don't get as much neutropenic sepsis as you might expect, it's still definitely compromising, and I would definitely advocate people having a 3rd dose.
Right. We heard the other day that a GP had actually had the same reaction and said, "Oh no, you're not really on chemo." So, well, I don't recommend it. So there's a lack of knowledge, I think, of education around that, and I wonder if there's a way we can persuade the ministry to describe what qualifies somebody for that 3rd dose and being immune compromised. Can we change what's on their website? Ask them to do that. or what else can we do to make sure that other people don't hit that wall?
Yeah, I mean, in my centre, generally when we're seeing people in clinic, we're discussing what's going on, and we can either do the vaccine prescriptions ourselves, although we've been encouraged to pass those on to the GPs. If we do that, you have to provide further information. So I'm just doing them all myself, to be honest.
Great.
Just looking at the guidance here, the third one that came out, well, I received it yesterday, it probably came out in the days preceding. And I entirely agree that the lists of medications are examples, and it very much talks about clinical judgment across the board. So I think that whilst it sounds like it would be fantastic for more drugs to be included in the list of examples, something not being listed is not an exclusion, and obviously your oncologist would be the appropriate person to weigh in as to whether it was appropriate or not.
Yes, okay, well, let's hope that not too many nurses and GPs put people off getting their third dose. So we talked about Ibrance there, and we have a question tonight. Palbociclib tablets I'm taking on a 21-day cycle with 7 days off. I understand it stops cells dividing, not just cancer cells, but all cells. I'm double vaxxed. In the event of me contracting COVID, how will my immune system fight the disease if the Ibrance inhibits cell growth?
I think it's only mildly immunosuppressive, to be honest. And the vaccinations that the lady would have had would still be likely very effective. And it just promotes the need for the third dose as well, rather than considering stopping palbociclib or anything. I mean, you just have a think about it, or that we're using a whole range of drugs which are much more toxic than this vaccine to try and control the breast cancer, whereas the vaccine is extremely well tolerated and it's saving lives. So we need to be promoting that.
And I just wanted to say, I mean, I think some people have asked me a bit about timing of having the vaccine, and there are some studies that have shown that it really doesn't make a difference where you have the vaccine in the cycle of chemotherapy or palbociclib, but it doesn't really change the effectiveness. So I think that's probably not something to get too caught up in. It's best to get it as soon as possible, the most convenient time for you when you're feeling right to have it, and I don't think that changes the effectiveness of the treatment.
Okay, we have a question. I think we've answered this one. After having a third dose, are you still okay to get the booster shot in 6 months' time? And I think we've heard the answer to that is yes, absolutely. Now, this is an interesting one. Do we have the data, Morgan? How long are you protected for with the third dose?
I was actually going to say that before. So the third dose, that's quite a new thing. So we don't have that information. What the aim is for that third dose to really bring immunocompromised people in line with non-immunocompromised people. So we would expect that would then go on that same trajectory of perhaps around 6 months. But I don't think that the data is there yet. And as to whether there's a different timeline that is observed. But the fortunate thing is that we're ever so slightly behind the rest of the world down here. And so by the time that situation rolls around, I think we will absolutely have that data to inform that decision making.
Yes, that's kind of a great thing that we started late on all of this, because it's as if the rest of the world's population is a monstrous clinical trial that we can see the data from before we have to make those decisions. Okay, so here's a question from someone who wasn't able to attend tonight, but hopefully she'll be watching this video later. What's the best way to protect ourselves from unvaccinated people who insist on visiting?
I think this is a tricky one, because our relationship with our whānau and our friends are very important, and you don't want to offend people and feel bad, but it is important to protect yourself. And I think people would understand if you explain that you have cancer and you're immune compromised and you do have to take care of yourself and protect yourself. That that is a valid reason to say that people can't visit you if they're not vaccinated. And I think that if you explain the reason politely, then but also say you respect their choice and that you wish to still remain their friend, but unfortunately just at the moment you're not able to have them visit because of your own health fear concerns.
But if they do visit, you've got to follow all those other social measures that Morgan was talking about, and that can compromise the quality of the visit. It's causing enormous tension between families and family members.
I think that's quite right. And maybe, you know, if it's really important they visit, then perhaps you could arrange a situation where you're both outside. It's, you know, really well ventilated space. You're both wearing masks, you're socially distancing, and then, you know, you're doing everything you can.
I think the outside thing's really key. Yes, we keep on hearing that we're just not seeing the spread occurring outside. So if, you know, it is an incredibly important person to be seeing, then outside, you know, with a mask would be your much safer option.
Right. And there's another part to that question. The person who's asking that is actually vaccinated, but I guess that all of that applies whether you yourself are vaccinated or not. With your advanced breast cancer, you want to be as safe as possible. Yeah. Okay. All right. So we don't have any more submitted questions. So, oh, here we are. Yep. What happens if your blood count is below 1 while on something, palbociclib? Can you still have the 3rd dose while on palbociclib? Yeah. If you've got a low blood count, can you still get your COVID shot?
Well, it's the lymphocytes, not the neutrophils, which are critical in developing your immune response. I'd still be supporting the vaccine and its effects with those numbers.
Right.
Yeah, agree. Yeah.
Good. Okay. Any other thoughts, people?